Eventually, I did start giving keynote speeches about it. I was writing about it. I'm performing on-stage monologues about it. And as part of all of this, I'm playing the 911 call over and over and over and over and over. So it really is therapy. And it was actually the most
your
effective
exposure
kind.
therapy. No, exactly.
I'm a genius.
How to be patient.
Welcome back to How to Be Patient, the podcast where we learn how to and to engage with patients. I'm your host, Preston Roche. I'm joined by Margaret Duncan. And we have a guest today who will introduce themselves.
I am Kristin Flanary. I might be better known to your audience as Lady Glaucomflecken, which
Hi,
is a
Kristin.
ridiculous name.
And one of our producers.
That's right. I forget. I do a horrible job of introducing myself. I'm just I don't know. I'm a girl. I do things.
Yeah. Well, I mean, so really this is just a discussion of producers today. So it's a round table. You have all the big brains in one room.
Some are invisible and others are not.
Well, today we have an interesting episode. We're going to be talking a little bit about dissociation, especially as it pertains to trauma. And I know that you're writing a book, Kristin, and with kind of like a cognitive neuroscience focus on that. So hopefully we'll have some relevant discussion there. But before we get into that, we're going to bring you into our tried and true tradition of having an icebreaker, like we do on every episode. So today's icebreaker is, what is a recent daydream that you've had?
Oh, a recent daydream. I daydream all the time about running away from my family, escaping to a tropical island.
And what's on this tropical island for you?
Just, some Mai Tais, a lounger, some good books, sunscreen. That's all I need.
Oh, that sounds really nice right now, actually.
Preston, when was your last vacation?
I think it was February.
Yeah, that's
it's been a little bit. 7 months or so. I've been thinking about how I need one. I don't have one scheduled till January.
Daydreaming. What about you, Preston? What's yours?
So I recently watched The Secret Life of Walter Mitty. You guys know that movie? It's a Ben Stiller film where this guy works at Life magazine. He's a negatives process manager. So he processes the negative photographs from film, and he daydreams all the time. So he creates these fantasies about things he wants to go do and travel, and then he actually acts on them and does get to go out to Iceland and ungovern Afghanistan and explore and get outside of his office. And I think I've been following his daydreams recently. For some reason, I've been obsessed with natural light, mostly the lack of, I guess, because for some reason in so many physician workrooms or just clinic workrooms, there's not a single window to be found. And that just it just drives me nuts.
That doesn't make you feel warm and fuzzy and ready to care.
Yeah, I'm just sitting in this dungeon, basically, is how I see it. So I daydream a lot about being a tour guide. I was how fun would it be to just lead hikes in New Zealand? And I'm just gonna abandon all of medicine, and it doesn't matter if I don't get paid a lot, at least I'll get to be outside during the workday, and I don't have to sit here chained to a keyboard typing documentation all day and then leaving when it's dark out.
That's very sad.
So those are usually what my daydreams are about these days.
Okay, so vacation for you as well.
So far, it's a strong escapism theme.
Mm-hmm. Yeah, really.
I feel like you're not going to like my answer. I feel like Preston's going to be like, Maggie, you're lying and you're being annoying with this answer, but I promise you I'm not trying to be annoying. I recently got so I walk quite a bit to commute to work in Boston, and I recently got Pilates certified. And so I feel like what I daydream about now is I'll put a playlist on and be like, what is my class going to be to this in 2 weeks? What is these are the sequences, but it's I'm not doing it to plan. I'm not formally planning. It's just I'll be walking and listening to music, and that is where my brain goes, and I like it.
No,
so.
I do that all the time. I'll be listening to a song and be like, how would I look in a music video for this song? Or or if I was in a movie and this was the score right now, what would be happening in the film?
Yeah.
Were you one of those kids, Preston, that pretended that you were on a late night show and you would come up with the answers to questions no one asked you and say them in the mirror?
That's him now.
I don't know if I was the late night show host. It was probably more like street interviews. Oh. I think I always saw myself as like pushing away or hiding from paparazzi.
Yeah.
I would daydream about that. I don't think I ever made it to the stage with Jimmy Kimmel though.
Okay.
At least
You're
in
more
my
of a
daydreams
Daniel
as a kid.
Day-Lewis kind of figure.
Yeah, exactly.
Okay.
No, I think that's a good fantasy, Margaret. Like, and I see how it has both like a therapeutic and like utile function.
Yeah, I mean, I guess I feel like it's like not a fantasy because it's like I then use some of it for the class. I think if you'd asked me this 6 months ago before I got trained, it would have just been like, here's what I would do if I was doing this. Like literally, this is like what would happen. I'd be like, well, if I could go to a perfect class, it would be programmed like this, and it would be this kind of music, and I would like leave class and be like, I wish it had been this way. And then you have like enough of that fantasy that eventually it's like, I could actually just get trained in this. Like I could actually do it.
Yeah.
So Kristin, leave your family. Preston, leave medicine. That's what I'm telling you, is you should actually.
Good advice. A psychiatrist told me to, guys. I don't know what to tell you. Sorry.
Yeah, there's no going back now. And no refunds, by the way. So this is a great segue into like kind of even just the definition of what dissociation is, because it's any amount of disconnection from your environment. So by definition, daydreaming is a very mild form of dissociation, but it's one that you can easily control and snap back out of. And more to come on that. But before we kind of continue to dive into this topic, Kristin, I'm really curious about like what your relationship is with dissociation. So to give everyone some background, Kristin actually came to us and said, hey, I have some questions about dissociation, depersonalization. I kind of want to get to chat with you guys a little bit more about it. So inviting the listeners into this round table, let's catch them up on the conversation.
Yeah. So I first got interested in dissociation when it happened to me. So
reasonable.
Yeah.
Reasonable.
So 5 years ago, for those who don't know, my husband, who's Dr. Glaucomflecken online, he had a sudden cardiac arrest in his sleep, and I did 10 minutes of CPR on him, and then, it was 3 or 4 more days of like, will he, won't he? It's like first, will he survive, won't he survive? Then it's, will he have cognitive function, won't he have it? So just a lot of kind of prolonged crisis mode. And then after he came home, I expected to just like feel better, right? Like relieved, yay, it's over. And I was relieved that he was home, but for the most part, I just sort of felt nothing. And I sort of lost the ability to like follow conversations. Like people would say something and I would hear it, like the sensory input is fine, but it just sort of kind of exits my mind a second or two after it entered. So, I couldn't hold on to it in working memory long enough to really like make sense out of what they were saying or to formulate a response back. And this was really curious to me because I, at the time, was working in communications and marketing. And so like language was sort of a big deal for me. Like this was a problem,
Like it's almost central to everything you do.
Exactly. Yes. Yeah. And I'm like a writer and a speaker, and it's very central. So, and then I had a background in cognitive neuroscience. So even in the moment, like at the time, I remember kind of thinking, this is interesting. Like, I wonder what's going on in my brain. And I didn't know that it was dissociation at the time. I called it the quiet place. Like that's how I described what I was experiencing because of that sort of loss of language. And then also just sort of like even my thoughts didn't have words, which was strange for me. Like it was just sort of white noise in my mind. And I was sort of like staring off into the middle distance all the time. So I was curious about it then, but then now it's 5 years out. And like you mentioned, I'm writing a book about that whole experience, and I'm bringing in that neuroscience piece, as well as some other, pieces. But I thought it'd be interesting to hear from you guys what you know about it and, get some free research while I'm here.
That's actually the purpose of our podcast is free research. So
Okay,
you
good.
came to the right place.
Not wrong. Not wrong.
Yeah, you hit F12 on the vending machine for
Yeah.
Preston and Margaret's opinions, and the whole bag of chips is coming out anytime now.
F13 is a puppet. It's a
Oh.
sorry, that comes out.
That one's broken out of
That
order.
one's broken.
Sorry.
It's not. Should we bring it back for season 3? But yeah, but it sounds like you mentioned not knowing it at the time and now thinking about it, recollecting, obviously over the last 5 years, but also in the specific process of writing.
Mhm.
And I wonder, at the time or close after, did you put a name to this only in the last couple years once you were sort of still noticing the pattern? Was there a thought that you had towards like, this was a traumatic experience? Am I experiencing like a PTSD type thing? What was the timeline on that?
Well, I called it The Quiet Place pretty early on, as is not surprising. I don't have great like memory of a good chunk of time after that. I just have like little fragments, but I want to say I could go back and look it up, but I wrote an article, published it in the Journal of Cardiac Failure, where I wanted to explain. This was very early on before I started talking about co-survivorship. I think it was before I'd even found that term. And I wanted to explain to healthcare professionals what it is like, because at this point, he had had cancer twice and now this cardiac arrest. And so this was like my third experience of like a really serious illness, going through it together. And it's happening in his body. So he's getting all of the like, he's the very clear patient, right? And so rightly so, he's getting medical attention. He's getting, all the things that a patient should be getting. But it always felt to me like that's only half the story. Like my life is just as impacted as his life. His body maybe is more impacted, but our life together, like that, and I'm facing a different set of challenges. Like I'm facing the possibility of losing this person that I love and that the father of my children, and we've built a life together. And so by the time it was, the cardiac arrest, and that one was the worst of all for me. Well, for him too.
Let me be clear.
Yeah. I'd had so many bad experiences in clinics and hospitals. Best case scenario, I was ignored. Worst case scenario, I'm going to be writing more about this in the book, but I don't talk publicly about it that much. But certain things happened while he was in the hospital for the cardiac arrest, where I got scolded. I got, it sounded almost like I was blamed. Like the cardiologist said when he was still in the ER and they were running all these tests to see like, what is it that happened? It was a big mystery. And so he said to me, I would have liked it better if you had seen him collapse. And I totally understood what he meant, right? That like he meant I would like it better if we knew how long it had been. Yeah.
Most emotionally sensitive cardiologist.
We love you guys. We know we can't do your job, okay? But also stereotype. Preston and I wear tweed and glasses, okay? Sometimes the stereotypes that your husband does
you wouldn't trust me with a wire.
Yeah.
Yeah.
But yeah, that was, so it felt really bad. So I was writing this paper to try to explain to healthcare audiences what this perspective is, this person that comes in with the patient and why that's important for them to consider. And so I had to try to figure out a way to write about, in a concise way, this gigantic emotional experience that had really been 7 years in the making. And so I just tried to describe the effect that it had on me to have done CPR on him. And so in writing about that, that's where I came up with, I had to, I don't know, I didn't have to, I guess, but I felt like I needed to call it something.
I mean, you kind of had to. Like, you had to find a name for this.
Yeah, I had to name the experience.
Huge character in, like, kind of the inability to process emotions or thoughts coming in and out of your brain. Like,
right.
That was driving factor.
Yeah.
I think there's also, like, quite a bit of focus, at least in the last couple decades, on how do we be there for parents who our parents to kids who are terminally ill? Or how do we be there in like memory care for people whose spouses or parents or whoever that they're taking care of are going into like hospice or losing memory?
Yeah.
And those kind of have established literature, and in some high resource places they have different ways of support. But I think what you're saying is for something like this that's acute and sudden, or for middle of life oncology concerns, there's not
Well, even then we were like in our 20s. So it was
okay, yeah. So especially then, there's not a like, it's a different set of questions and way of support than than these other groups of people that there's been more focus on.
exactly. Yeah, there's little pockets in healthcare that have figured this out, right? There's child life specialists in pediatrics. There's palliative care. They're really good at this stuff. Social work is really good at this stuff. But the problem is healthcare is so siloed and, resources are sometimes scarce. And so it's like I would hear from people sometimes when I share my story that would say, oh, at my hospital, we have a chaplain or something, right? And I'm like, that's amazing. But also, that shouldn't be a point of pride. That should be like a normal thing,
Yeah.
like a little more interdisciplinary sharing of information would be really useful.
Yeah. Sorry, Preston, I interrupted your question.
Oh, no.
Preston planned the episode because I took
I was
boards
just
yesterday.
sitting here, like, giving a moment to think about how many problems will go unsolved in, like, the systems issues among hospitals.
So I know.
And we are trying, but progress is slow, I would say, especially in the non academic areas.
Yeah. Well, and that brings up a good point that I always try to make, which is like, I don't blame individual physicians. I don't even think that it is physicians' responsibility as a group to like provide psychological care to people, right? I want the physician focusing on the medical care. That's what you guys are best at. That's what I want to be happening. I just think that the system has a lot of gaps in it, as we all know. And this is one of them, that seems relatively easy and, I don't know, maybe not too expensive to close because we have figured it out in these other, like, certain parts of healthcare.
Yeah. So to kind of switch gears, and focus on this quiet place that you talk about. So I imagine you kind of started doing some investigation as to what this might be. And I'm curious what you found.
I found a lot of nothing because what do you Google?
Why is there a quiet place inside my head?
Right. Like,
on r/
I don't know,
quiet
get some
place?
song lyrics or something.
That's a John Krasinski movie.
So yeah, that's part of why I talk about co-survivorship a lot, because I want there to be a term that people can Google, right? Because I didn't have one. But the other thing is, like, I did a little bit of investigating, but for the most part, I wasn't really that capable of it, right? Like, it takes way more executive function than we think of, than you would think to, figure out something like that. Any kind of self-care, really. Like, people would say to me, well, I hope you're getting help for yourself. Hope you're finding a psychologist or something. And truthfully, I could not. Like, that, to look for somebody in your area with this kind of general specialty that accepts your insurance, has availability, that's a lot of steps of executive function that is normally not a big deal. But in that state of mind, I literally couldn't.
Right. And presumably you also increased care taking in some ways, even just in helping Will adjust back to life. I don't know, helping, your kids deal with.
Yep.
Yeah.
And his parents came up, and my parents are here, and, everybody's emotional, and I still have my job that I have to go back to. There's a lot.
Yeah, and it's tough because the symptoms of the disorder also, like you mentioned, impair you from actually treating it.
Yeah.
Psychiatry is like one of those
Psychiatry classic.
unique fields, where
Yeah.
it's kind of like we hold our own hand and punch ourselves in the face, at least as far as the disorder goes. Like, imagine if, like, having, like, I don't know, hyperlipidemia also, like, made your brain just, like, hate PCPs. You're like... You're like, these high levels of lipids in my arteries just make me like not want to see the doctor. And we're like, darn it.
PCP, but
You're the one who needs to see it the most.
Lipids, the voice of the lipids are telling me he's an asshole.
They're telling you not to take the statin. Like, there's a steak. Like, you go to a steakhouse, and they just write, like, in barbecue sauce, and they're like, don't take your statin. It's actually poison.
I mean, this isn't very different than the anti-vax argument, you know?
Yeah. Well, I kind of want to offer some more clinical definitions. So I have the DSM pulled up here. Look at this big boy.
Ooh.
I'm showing
Where are we on
this
now? I'm out of touch these days.
Okay, we're on the
5?
DSM 5.
Okay.
But with the remix, the text revision. Yeah.
Nice. TR.
So I am on page 343, and this is
listeners, to open your DSMs.
Yeah.
Yeah, so let's all open to the same page.
Everybody
Okay.
open to the page right now.
You'll see at the bottom F48.1 diagnostic criteria for depersonalization, derealization. So I'm going to read you the definitions for these two kind of subsets of dissociation.
Wait, before you read it, I want, Kristin, when you listen to it, I want you to pretend it's you 5 years ago. It's you a month after this all happened. And if these words, if they were said this way to you, if you would have recognized your experience, or if the words wouldn't have been evocative enough for you to recognize yourself in this.
Okay, that's a good question.
Experiences of unreality, detachment, or being outside observer with respect to one's thoughts, feelings, sensations, body, or actions. For example, perceptual alterations, distorted sense of time, unreal or absent self, emotional and physical numbing. And then number 2, experiences of unreality or detachment with respect to surroundings. For example, individuals or objects are experienced as unreal, dreamlike, foggy, lifeless, or visually distorted.
I would say about half of that I would have been able to pinpoint as, yes, that's happening. Like, foggy jumped out at me. Time was, what is time? Like, I don't know. There was no such thing. It was just, I was awake, I was asleep. What were say it again, and I'll as we go, I'll say.
Feelings of unreality, detachment, or being an outside observer with respect to
so
one's...
definitely detachment. I felt very detached. And I did sometimes feel like an outside observer. That was more like during CPR. I had one of those like floating, out-of-body experiences, you know, where like our life so far just flashed before my eyes. And, you know, like that was during CPR. I'm not sure that it was as much after the fact, though. But definitely detached and like numb, I think, was in there.
So you had this almost like full dissociation or full like kind of detachment during the episode, and then this lingering numbness and flexing or shrinking of time afterwards.
Yeah. And there were a few more things in there too, but I don't know. You'll have to tell me, is a continued loss of memory one of the effects of all of this?
Well,
or am I
get
just
into
getting
that,
old?
yeah.
Either way.
I mean, I think one of the things we haven't explicitly stated, and listeners, you know I don't diagnose anyone on the show or in any way, but when we are talking about what you went through, especially that there were prior episodes of acute health concerns, and just like whenever we're talking about dissociation or derealization or depersonalization, we're usually talking in the trauma field, right? So we're not necessarily only talking about PTSD, but we are talking about something that happened that made it was either a lot of trauma, people will say too much, too soon, or too fast is what we define trauma as, that makes flight from the experience necessary. The differential of this being thinking about people who daydream more because they have ADHD at baseline or other attentional concerns. But that just to say that is often the conversation we're having when we're talking about the topic that we are right now.
Yeah. Now that we've kind of like at least set the stage for the players, and to double clarify, we're not diagnosing Kristin with a dissociative disorder, but we're just saying that this is something that we define and that maybe she identifies a little bit with. So when we come back from this break, we're going to actually talk a little bit about the neuroscience of dissociation. And this is coming from me, who's not an expert, but did my best to read about it, and, and feel free to grill us as we kind of roll through this. And then Margaret's going to help by talking a little bit about some of the therapy and treatment approaches that we have to dissociation and how it relates to trauma. So see you soon. And we're back to talk a little bit about some neurobiology of dissociation. So whenever when you're in med school and you're kind of doing your flashcards, I think most people come across this connection between ketamine and dissociation. That's kind of like classically what we recall. If you take a bunch of ketamine, it can like induce dissociation. The same can be true for anything actually that antagonizes this specific receptor called NMDA, which is mediated by glutamate. So like dextromethorphan or Robitussin also has a similar effect if you take it in high enough of a dose. Not recommending that anyone does that, but that's
Is that
why
like
some
the
people
buzz
do.
sort of that you feel kind of like, woo, floaty?
Yeah, maybe. So like Robitussin has like 3 different levels of a high that you can get from it. We don't need to go into detail about this. But if you
We're
have
not
like
recommending-
900
not medical
milligrams, you can
advice.
like
That's the first
you can
Patreon
induce
episode.
dissociation. Yeah.
It's just Breaking Bad.
Anyways, yeah. So
This is the beginning of our villain arc on this podcast.
yeah. Welcome to Evil Psychiatry, where we break into like what your drugs are doing. Yeah, but we do good psychiatry here. So I that was kind of actually for a while how I best understood dissociation. I was like, okay, glutamate, NMDA dissociation. That's about it. That's all I really know. And so I kind of like for the last like day and a half or so went on a bit of a journey trying to like really understand like what is actually being affected by glutamate and who's hosting these NMDA receptors to cause this like dissociative effect.
Yeah.
And in order to tell this story, I think we're going to step away from the neurotransmitters for a second and talk about how your brain works in its environment and how it produces memory.
Small topic.
Yeah, no, super
It's a little
easy.
light.
Brain
And I'm gonna do a great job of distilling what I've read into a way that's understandable to everyone else, while I also try to understand it. So basically, I want to start with the concept of salience. So if something is salient, it means it's important or it sticks out to you. You know, it's relevant, and that's kind of the name of the game for a lot of our attention, or like things that we draw our attention to. We have something called a salience network that is essentially always scanning our environment and trying to figure out what's important and what's not. So if you kind of like look around your desk right now, or if you're listening while you're in the car, try to like take into account how many pieces of stimuli that you're seeing right now. Like you maybe you see the steering wheel, or maybe you see a car in front of you, maybe you see a tree, maybe you see a sign. Like that's like 10 you can count. But if you were to expand that, you could go down to like the individual like granules, like single pieces of hair everywhere. And that's just your vision, right? So technically there's an infinite amount of things that you can visually take into account. Same applies to your hearing. Same applies to smell, touch. Like your brain is always overwhelmed with essentially infinite stimulus. And then it has the job of like narrowing it down to like what's important and what's not. And then now you have like a bunch of stimulus that you've identified as important, and you have to assign emotions to those things, because we need to triage like what do we want to act on first, right? Because let's say you're like out in the woods, right? And a bear's charging at you. You may have managed to identify that like the flower is an important stimulus, the tree is important stimulus.
Why I wouldn't survive.
The cloud.
pity.
Yeah, and the bear. So it's like, okay, all these are important, but like the fear emotion takes priority, hopefully. But for Margaret, it might be whimsy, and she's like, whoa.
Whimsy maxing to the
Look at
death.
this daisy.
Continue, sorry.
I guess the point is that like we, within the salience network, use these emotions to kind of like triage and create a hierarchy of like what's most important to pay attention to at the time. And so that's kind of like one aspect of it. So you're assigning value to these things, but then at the same time, you're also like, by adding emotions to those things, you are predicting what will happen. Because the other thing that your brain always is trying to do is predict what's going to happen, because we need to be proactive, not reactive, right? Like if I see a bear and it's charging at me, my brain's going to predict that it's like going to attack me, versus if I see it like sleeping or just like rolling around, rubbing itself against a tree. Like those should induce two different like predictive models, basically. And that kind of brings me into our next like topic, which is this kind of prediction and prediction errors, which are like two things that kind of induce anxiety and emotion in us. So basically, to summarize, we have infinite info. We have to narrow it to what's important. We have to prioritize it, and then we make predictions, and we develop beliefs off of those predictions. Hopefully I didn't lose everyone. Does that all kind of make sense?
Makes sense, yeah.
Okay, awesome. So now this all applies to things that are benign, right? Like we're making predictions about whether or not like a pencil's going to fall if I drop it. But when trauma gets involved, things kind of start to go awry, I guess. And really what I found is that a lot of this stuff comes down to a really important part of our brain that's called the insular cortex, or the insula. Yeah, Margaret's like, hell yeah, the insula. Yeah.
She matters for eating disorders and chronic pain. I love.
Oh, okay.
Yeah. So the insula, it's in your temporal lobe, and it kind of basically does what I described as far as taking into account all this different sensory information and then uniting it into your concept of self and space. So you're like, okay, I'm getting all this sensory input from my eyes, ears, nose, taste buds, from my skin, and also my ideas about what exists around me. So my prefrontal cortex, my memories, they're all kind of coming into your insula, which is like, okay, this is where I am in space and time. Like this is how I've got my bearings. And that is really closely linked to both your amygdala and your hippocampus, which manage your fear and your memories. So let's introduce like a traumatic event, like let's say like a car crash or something. You have this prediction error essentially because I imagine you're surprised. So you're driving along, you're not expecting to be in a crash. So you're trying to predict something. You err in that prediction. And then so you have a lot of extreme fear, basically, that like bathes the entire region of your insular cortex and your temporal lobes, your hippocampus, all with norepinephrine. And these regions are all rich in like beta receptors and alpha receptors that are all going to basically be like hyperactivated by all this norepinephrine because you need to do it. But it's in such a high like drive that things start to kind of malfunction. So now it's like basically the pathway has been short circuited, and anytime you see something that reintroduces this similar memory that's been encoded, it jacks it up again. And it creates this huge like autonomic response, which is also kind of a problem. So that's where kind of like the prediction errors come into play. Like we are constantly predicting, but we don't want to be wrong again. So we're inappropriately assigning like 110% fear to random benign stuff that we see because we're like, for the love of God, I don't want to get in that kind of accident again. I'll do anything to avoid it. If that kind of makes sense.
Mm-hmm.
And then now to kind of like come back to these like neurotransmitters, they are the ones that actually play a huge role in encoding memory, which is why it matters so much for like ketamine to induce dissociation. So, like I mentioned earlier, traumatic or strong emotional responses are very important to encoding memory. We actually have known about this since like the Middle Ages. There was an old proverb that if you wanted like a child, proverb. Sorry, not religious.
I was going to say either you're Canadian or you never were religious.
Ye old proverbs.
Yeah, one of them. Basically, they were like, if you want a child to remember a wedding better, throw them in the river at the end of the day because the trauma of being thrown into the river is going to like sear the memory into their mind.
So you're saying abuse children to help them remember.
Yeah.
Well, maybe that's where spare the rod, spoil the child came from. Preston, that's another one you probably don't know.
Yeah. No, I don't.
You don't?
So, sorry, I'm continuing with my monologuing here.
Okay, sorry. Continue. It's a good monologue.
Basically, basically you're trying to encode these memories, and when you have a strong emotional response, like say something firing from your amygdala, you have extended release of glutamate, and that glutamate helps to encode the memory. And especially it helps to encode these aversive memories. So it was super interesting. One of the studies that I came across, they had people taste like different objects. Like they would taste like bad tasting objects, like aversive objects, and just like benign ones. And then for the people tasting the bad objects, they split them into a ketamine group and a control group. And the people that took like small amounts of like dissociative, like doses of ketamine and then had the adverse experience were less likely to remember it as adverse than the people that did it.
Hmm.
And then they found that when they gave people like pro-glutaminergic drugs, so things that like there's actually GLUT reuptake inhibitors, believe it or not, which I learned about. They're not in practice. They've been used in studies, but yeah.
Just kidding. I know that that's not that. I know enough neurobio listeners to not actually think that. Just to clarify.
Yeah, but those would actually help us encode memories by inducing more glutamate. So you might be like, okay, well, where does dissociation come in any of this? We basically just described that you have like a really strong reaction to memories now. And what I'm functionally talking about is hypervigilance, which is something that's described in PTSD. But here's the problem, is that this whole circuit goes on hyperdrive so long that it's almost starts to numb itself out. Like you have to downregulate your response in the insula to all this super strong input that's coming in. But you can't really differentiate between where that's coming from, if that makes sense. You can't be like, oh, like I'm only going to downregulate it when I see one of my triggers. You're like, I'm just going to downregulate it all the time. And then now we're starting to like block some of these pathways. We see less function in insular cortex, and that's thought to be related to basically us starting to shut down these pathways that interpret our stimuli in order to basically like protect ourselves, but that leads us to numbing our emotional responses to things. It leads us to losing our sense of self within like time and space, and it leads us to like having trouble monitoring our own bodily functions, which are all symptoms of like dissociation functionally. So in short, we have a really extensive system that is constantly monitoring our environment, prioritizing it, creating a hierarchy from it, and then encoding it to memory with emotions. But when you hit it with one that's so strong, the whole thing gets kind of thrown out of whack, then you kind of just start to turn off the faucet so that you don't have to deal with it. I think that analogy of itself is like, I think, a great way to describe to patients like what their experience is like and why they start to become so emotionally numb.
Yeah. So the first question that pops to my mind, and it's okay if you don't know the answer because I didn't give this to you ahead of time. So in my case, the acute crisis part was, a few days, and then the dissociation was like months, years. So like if we're just talking about like regulating neurotransmitters, like at what point is it like, well, now they're totally depleted. And so, like, does that ever, I would assume we're trying to get to homeostasis all the time, right? So I'm curious about the time difference, the duration difference between the two states.
I guess let me take a crack at this, Preston, and then you can correct me if I'm wrong. So there's a bunch of things that lead to, we're talking about neurotransmitters, but really what we're talking about is neurocircuits, which are modulated by neurotransmitters. And I think that's important because there's a lot that goes into what an individual's circuit that makes them higher risk or lower risk for developing PTSD or depersonalization, derealization in this, like when something happens. Like, so for example, one of the things we know from a population level when it comes to like trauma-related disorders is that when a natural disaster happens, so when a lot of people go through a sudden event that can be called a trauma, about 90% of people will not go on to develop symptoms of PTSD. And I think what's important about us thinking about this from the neurotransmitter perspective, but is thinking about everything that one person's circuitry will do when there's this modulation and how the learning sticks or doesn't stick. Because what Preston's talking about is a neurotransmission, but it's also kind of a rewiring, which is why the symptoms can last so long after a single event, which was also not really a single event from what you're saying. It was that event, but it was also the events before.
Yeah.
Right? And so if just that had happened, would you have developed these symptoms? Maybe. If you only had the first event the first time he got sick in that way with that support system or not, would you have had it happen? It didn't happen until this time.
Yeah.
So I think that's just in terms of like not over. It's hard to kind of explain these things about neurotransmitters while also recognizing that neurotransmitters are like adding a bunch of switches to a bunch of wires that we only kind of sketchily know are connected together so far.
Right.
And Preston, correct me, please. Thank you.
No, I agree. Like what I'm using neurotransmitters to talk about what is heightened sensitization of certain circuits that we're describing. So like the fact that it would be expected that some of them are lingering, but like Margaret said too, it affects everyone very differently. So it's hard to just kind of like call out or guess what the timeline would be.
Yeah.
Preston, are you telling me I got a neurobio question right?
Yeah, I am. I thought you did a good job of describing that.
Thank you.
Also, neither of us are neuroscientists, so we're just like
we're not. But also, half people online who are like, "I'm a neuroscientist," aren't neuroscientists either.
Good point. Yeah. I mean, every time I do this, I just picture my brother-in-law Jonah, who's he's like a PhD neuroscientist at Harvard, and he always just says the brain's too complicated for any of us to know.
Period. That's like that
and then he just ends. So he's probably listening to this going like, Preston, the brain's too complicated to describe like this.
And we agree with him.
Yes.
That's like literally
Jonah, we agree.
My patients are so sick of me being like, someone was like, how does an SSRI work? And I was like, well, I spoke for 5 minutes and I was like, and that's actually a pretty bad probably explanation of how they work.
Yeah.
And they were like,
if I even try to explain this to you, I'll make it worse.
Like clinically, I need you to trust me, bro, a little on this.
It's actually probably better if you just think it's magic.
Yeah.
Did that answer your question?
Yeah, I think so. I mean, I don't know. It's like also a kind of an impossible question. So, but yeah, that is a good point that it's not just the neurotransmitters. They're doing other stuff.
Yeah, well, I think her question was fundamentally like, okay, well, if I still have these like lingering symptoms of dissociation, how long can I expect them to last? And Margaret and I just said, I have no idea.
The brain is too complicated for us to know.
Yeah. How dare you?
I think one of the question, if the question is how long will they last? I mean, I think the clinical question becomes observational studies on people who have these. If this symptom is related to other symptoms, and we look at like trauma disorders, what do we do when we compare groups who have not gotten treatment and just natural through time? If someone has these symptoms at 5 years out, what is the likelihood that they'll have the symptoms 10 years from now, 20 years from now? Which, again, I will not diagnose you, but would be interesting from the PTSD data in terms of PTSD is not really known as a like recurring, remitting illness, but it can certainly improve over time for many people. Whether that's
for most people.
For most people. Does PTSD get better? I mean, like for PTSD?
Yeah.
Really?
Yeah. So like
what is
my understanding is that like even without treatment, like a lot of times PTSD symptoms will like slowly improve over time.
Because I can think of many. I don't know. I feel like it depends. Probably. I mean, that's a shitty answer. I'm gonna be quiet. But most of our illnesses do get better over time, and it's not like an episode of depression that was like unprompted. But I can also just think of many people who the PTSD untreated just worsens it. And so that's why I'm like, are you correct or not?
Well, yeah, I'm not saying that like taking someone off treatment, like obviously that's, but I guess what I'm saying is like your PTSD close to the event versus 10 years out. Like it's not like it's not like the PTSD is twice as worse. Like it doesn't gain momentum with time and deteriorate and continue to get worse like you would see in like a dementia syndrome or like schizophrenia or bipolar, schizoaffective. You know what I mean? I guess that's like what I'm comparing to.
Oh, I see what you're saying.
Those are progressive illnesses that will continuously get worse without treatment. Like obviously PTSD will get worse if you do not treat it or like take away treatment from it, but it doesn't progress in the way those other illnesses do.
Agree. Okay. Yeah, I see what you're saying. Yeah. I think we should take a quick break and then we can talk a little bit about approaches to this to help people with it clinically. And also, I think it's important for us to say a little bit more about, obviously, we don't read the DSM book to our patients. So how we describe this kind of thing to help people understand a little bit more of like what we're talking about. Because I think that the definition, like many things, and Preston, you talk about this quite a bit, like you can't just be like, do you want to end your life via suicide as the only way you address hopelessness or suicidality or self-harm? Like you need to have a different kind of language to actually talk to people in our work.
I'm like, it says here
Yeah.
that depressed people are hopeless.
Are you?
Are you hopeless? Are you pathetic?
There's no pathetic.
I'm just
in
kidding.
there.
That's not a criteria, but that's how a lot of people take it. You know, they're like,
Yeah.
I'm not hopeless. Like,
Do you feel okay? We will be right back.
Okay.
On that note, we'll be right back.
because I mean, like the definition of hopelessness is to be without
And we're
hope.
back, and Preston's still talking.
Yeah, sorry. And another thing about hopelessness, like the definition of hopelessness is to be without hope. So to think that, and hope is the belief that things may improve in the future,
Hope
or
is a
that
thing
there's
with
like,
feathers.
or it's that.
Or is that we just split into
Yeah,
our
it's a
stereotypes
butterfly
again.
Yeah.
Okay, Lana.
So, anyways, if you're like, I have no optimism or belief that anything will improve in the future, that is like by definition not having hope, which is hopelessness. But people often like will then equivocate hopeless to like an adjective of something that's like pitiful.
Right.
Preston, I feel like this, even though I didn't design this episode, I think this might be a good example to do a 2-minute role play where I pretend to be a patient experiencing this and you interview me for 2 minutes, and then we'll have Kristin weigh in and see what she thought of the interaction.
All right,
boy.
let's do it. You know I'm always ready for a quick role play.
Stop.
Do I need to leave the
You're
room?
And
Where's
I
HR?
drank some. I had I had some kombucha before this episode, so I'm just gonna try my best not to burp during this role.
Be like, are you ever? Let's just. Okay. I'm going to give you.
That was an imitated burp.
I'm going to give you a clinical vignette. Are you ready?
Okay.
Clinical vignette. It is going to sound somewhat similar to what we were talking about with Kristin, but I am going to change details, and this is not reflective of your situation, but I want to make it a little similar so you can see how you would talk to someone presenting during co-survivorship. Okay. 32-year-old female referred to you from her primary care doctor after unintentionally weight loss over the last year of 10 pounds with decreased appetite, decreased interest in prior hobbies, hanging out with female friends, sense of kind of overwhelming anxiety with taking care of 2 kids. Of note, spouse had significant illness, oncology, you don't need to know what it was, is now, as of a month or 2 ago, as of 2 months ago, is in remission overall, like doing well. Patient coming in a couple weeks ago to primary care wondering why they are still feeling quote unquote off, feeling not as present, and wondering if there's something wrong with them, if there's fatigue or they need like vitamins checked. Vitamins all normal, tested all the labs. Things look fine from that
EKG is
perspective.
normal.
EKG normal.
No anterior drawer test
What?
for the
Interior
ACL.
drawer? Oh, what?
Yeah. How are your knees?
Why are you asking that?
What's menstruation like?
It's fine. You are coming in now and you are asking her for your focused exam about the fatigue and the sense of overwhelming anxiety that the PCP reported to you. You have 2 minutes.
Okay. So, when I was looking over the notes from your primary doctor, they mentioned something about feeling tired all the time. Can you tell me more about that?
Yeah, I mean, I have 2 kids. I'm busy. I'm working. I think they mentioned to you that my partner has been sick for the last a little over a year. He's better now. So I've got a lot going on, and I would get tired before, but now it just feels like everything's always kind of, I don't know, fuzzy. It feels like I just can't like focus or be as like present to things, even like my kids, as I was, the rest of like a couple years ago.
Like you want to be there, but you don't feel like you're there.
Yeah, it's almost like I have to get myself to like keep refocusing back in,
Mm,
and like otherwise I just feel like I'm getting anxious and thinking about other things.
gotcha. So when you're in this moment where you feel you're taken away from the present, what anxious thoughts come into your mind?
It's like it's not even necessarily like fully formed like thoughts. Like
Mm,
it's just like I feel sort of like it feels like something's wrong, but I like don't know what's wrong. And
mhm.
like I'm trying to figure out why I feel like something is about to happen. And like it makes me like when I'll like feel it sometimes, it'll make me be like, oh, do I need to like double check the lock, or do I need to like text my partner and just double check that his like day at work is going okay, or like
Something bad's about to happen, but you can't put a name to it.
yeah.
And you go and try to find solutions to that thing.
Yeah. Or it feels like when I'm like with my kids, like it almost feels sometimes like they're playing and they're trying to talk to me. And I'm like, like I'm hearing them, but I'm like not actually with them. Like I don't feel like outside myself, but
Does it ever feel like things are almost dreamlike, or like there's like a screen between you and other people?
yeah, it's almost like I feel kind of like numbed to other people. Like they can't actually reach me.
Mhm.
Okay, time.
D- okay. I think the next place I was going to go with that is like try to get at like how you feel emotions, and I know you mentioned like feeling numb, but like really like when's the last time you've like felt anything, or like do you feel
Okay, wait, well,
joy,
let's give us one more minute then.
fear?
Okay.
Okay.
I mean, I think I like feel fine most times. The last time I like really felt something was probably like sitting in the hospital or in the clinic when he got diagnosed. Like I feel like the last time I felt something vivid, it was horrible.
Does anything happen during the day that brings you back to that memory?
I mean, what does like nothing that makes sense. Like I've had to like put different anything that reminds me of it, I try to like put out of sight, but I mean, I think about it like I don't know 20, 30 times a day on a good day. Everything he reminds me of it.
Mm-hmm.
Okay,
I
now
see.
time.
Okay.
Okay. Preston,
So yeah, actually, I didn't have to do that much. You did a great job of kind of like describing all of those symptoms. So in you saying this like I feel numb, I feel like I'm not there with my children, or like the emotions aren't like going in. You're pretty effectively describing these like feelings of attachment right, detachment with regards to one's thoughts, feelings, and bodily sensations. Feeling like you're going through the motions with your children, but you're like not actually present or there. So like that would be something that like almost kind of seems like this like conversation, but like we're pulling, I guess, the DSM criteria from the things that she's describing.
well, and you can see how clinically someone could present like this. And like if I was in a primary care clinic where there's like 40 other things they're trying to do with you, it could easily be chalked up to like, oh, it's depression, or it's like, oh, if I love
Hmm.
PCP, so I'm not going to put this on them. But if we're in a prior, like, sexist kind of way of viewing health, like, oh, all moms are tired. Like, you've been through a lot. Like, you just need to sleep more and da 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 da. Like,
Yeah, do you know how many times we heard that over all 7 years? It was like, he's tired, I'm tired. Well, that makes sense. You're in school, you're in training, you have kids, whatever. It's
Mhm.
just like, you're 20s and 30s, so you're not sick, you're just tired.
Right. And you can
Hmm.
see how, with less time or with less ability to ask questions of put language to this, that it could easily be chalked up to, oh, you're tired and you're like kind of down and anxious. Let's start you on a medication. And granted that a medication may still, like, people don't have to have diagnostic exact clarity for a medication to still help with this kind of thing, but it wouldn't lead us to the kind of clarifying discussion that would maybe help you the most.
Right.
Yeah, and like I think different from other specialties in psychiatry, the act of giving someone a diagnosis is therapeutic in itself.
Yep.
like if I like explained to you and wrote out the criteria and said like this is what I think you have and that like actually fits and is reflective of your experience, like that is treatment in and of itself.
That's something I
And
talk
we'll
about all the time, and that's why I like share that word a lot, is that it is the diagnosis, right? And there's something really powerful about language that if we have a name for something in a box we can put it in, all of a sudden we feel like it's resolved in some way. Like we can deal with it now.
Yeah, like one of the strangest experiences I've had in medicine, especially like when I was on internal medicine and you would diagnose patients with cancer who were like had this huge like unknown workup. They almost like had relief when they got the diagnosis of cancer after like months of going through this like battery of tests. And like in a lot of them, they would say, at least I have a name for it now. At least I know what it is. And like that was healing for them.
Yeah.
And the same is true for psychiatric disorders.
I think as well, right? Like it's such a confusing, if we think about clinically speaking, we think about these definitions of trauma and what causes someone to experience dissociation. If we think of that, then one of the principles of like trauma informed or trauma sensitive care are giving autonomy, giving language, giving space for like self definition. And all of that in a good diagnostic process can help people have more choice and more sense of their own story, which, as you're saying, Preston, can be in itself like help healing to some extent, as well as being useful in terms of direction of support, aid, clinical help that someone might need.
Yeah. And then all of that aside, like having the right diagnosis or correct diagnosis helps guide you to medications that are more effective. So like you can use SSRIs to treat PTSD or trauma-related disorders, but SNRIs are often more effective.
What is like? Give me some examples of SNRIs.
Yeah, so something like Cymbalta or duloxetine or venlafaxine or Effexor, those are the kind of the two names for those. The two different medications, brand name and generic. They are serotonin and norepinephrine reuptake inhibitors.
Is that
And
the same as Wellbutrin? Like,
so Wellbutrin actually is on the other end. It's a norepinephrine dopamine reuptake inhibitor.
oh, okay. So N and D, not S and N.
Yeah. So some people call it an NDRI.
Okay.
So
I do want to say there are a lot of people on sertraline for PTSD, and it is equally evidence-based as the SNRIs, just in case anyone's listening.
Yes. So
Yeah.
so I was actually I'll get to that too, which is like SSRIs have different efficacies, like different SSRIs. So like fluoxetine and sertraline are like more effective for PTSD than something like Lexapro, for example. And that has to do with like some of the like other subreceptors that are hit by sertraline and some of the subreceptors that are hit by fluoxetine. So fluoxetine actually has a lot of activity on the norepinephrine reuptake. It's kind of like an SNR light, I guess. And then sertraline hits a lot of dopamine receptors, a lot of sigma receptors, and other things like that augment in a different way. So yeah, Margaret's right. Like sertraline has equal evidence to support PTSD. I actually I haven't read a lot of papers on this hypothesis. So this is like kind of like Preston's hypothesis, but my thought is that if you have basically manipulation or change of how you encode memory from a traumatic experience when you're like basically bathing your temporal lobes in adrenaline from having like experiencing trauma, then if you have an SNRI, like the reuptake of norepinephrine, which you think would be stimulating, it actually helps like desensitize or downregulate some of like the postsynaptic reactivity to noradrenaline, which may help augment some of the traumatic experience. So big asterisk on that. It's just Preston's hypothesis for why SNRIs work. I don't know.
I don't disagree with your hypothesis. I also, though, think that a lot of this data comes from funding through the VA for PTSD. And in terms of population studies, we're not studying necessarily kids. And if we are studying people in the VA population, there's a high preponderance of comorbid chronic pain. I don't disagree with your hypothesis, but I think there are just many factors here that could be why SNRIs, which have more efficacy for chronic pain and trauma have a strong interrelationship in terms of like nerve signaling and increased central sensitization. So
Yeah, it could be both and like central
Yeah.
pain sensitization. Doesn't a lot of that happen in the insula?
it does. Yeah. Yeah.
So maybe it's two birds, one stone kind of situation. But who knows? We're just a guy and a gal hypothesizing about stuff.
Or, I mean, I wouldn't undercredit that. That, I mean, at least what I said is based in some real
Okay.
discussion on, like, I don't know. Interesting theories, though. And then
Yeah.
you should talk a little bit about like clonidine, prazosin. Although for dissociation, I don't know how much. And the other thing we're not talking about, which is the most evidence base for this, is therapies.
Mhm.
Like for specifically for dissociation and depersonalization.
Yeah. And I guess, Margaret, I'll let you cover the therapies for dissociation because I think I'm only really familiar with like desensitization therapy for PTSD that indirectly helps with dissociation rather than like directly
Yeah.
addressing the dissociation.
Well, I mean, I think that for dissociation, it's not. There's not necessarily a therapy that's directly going to be like, let's get them in their body, like will directly help it. I think
Like an exorcism? Get them back in their body. Find them. Where in the room are you
Well,
looking
like,
down on us?
okay,
I'm going to
this-
grab you and stick you back in your head.
This brings up a good point though. Like, what about things like EMDR? The whole like, I don't know. I don't know the names for them, but
Yeah.
like grounding techniques. You know.
I'm not going to publicly speak on some of these therapies.
Okay, I have no idea. I'm just genuinely curious.
EMDR is evidence-based for treatment of PTSD. There are, I
Okay.
think, are valid components of these, like what they're called somatic or bottom-up therapies that we have historically ignored.
Mhm.
The actual mechanism of some of these things as they are currently purported lacks some. There are questions that different parts of the neuropsychiatric community have about the validity of the purported mechanisms of like EMDR.
I'll speak on it.
Let's hear it.
So the desensitization part of it is like really what we know is effective. And that gets back to what I was talking about earlier, which is you're assigning this huge fear stimulus to something you see in your environment. So by basically exposing you to it, which is going to induce a fear response, and then seeing that nothing bad happened, and then exposing again and nothing bad happened, like you're getting reps in to almost like extinguish that hyperactive response that you're having over and over again.
This is so funny because I have always joked that my therapy, because remember I told you I couldn't like arrange therapy for myself. But eventually I did start giving keynote speeches about it. I was writing about it. I
Mhm.
performing on stage monologues about it. And like as part of all of this, I'm playing the 911 call over
Yeah.
and over and over and over and over. Like, so it really is therapy. And it was actually the most
so your
effective
exposure
kind.
therapy. No, exactly.
I'm a genius.
Hey,
You-
it's like called prolonged exposure therapy for like trauma. So you quite literally had some of the most active ingredients in doing that. I think one
Yeah.
other thing therapeutically that we have to think about is that for someone who has had a trauma and their primary concern is dissociation or derealization, we have to be very mindful that in this exposure-based work, which is the most helpful for kind of desensitization to the stimuli and relearning, there's nothing like someone getting mad at me or like avoiding talking about something or not showing up for appointments, I can tell that's happening. Some people are very good at dissociating and it looking like nothing's different at all. And so I think establishing rapport and letting things be patient-led is always a good idea, but especially if this is the way that someone responds to the trauma, like trigger stimulus.
Mhm.
Yeah.
Because it is a really effective coping mechanism in a way. Like if you literally learn how to just like suck yourself out of it. So you're like, oh, no, like I can go back in my turtle shell, or I guess out of my turtle shell. Like why would I want to try to expose myself to that, even though that's the way that you like kind of learn how to not have that reaction again.
Do you think it gets easier to like, can you pop in and out Once, like
the Avatar state?
yeah.
I don't know.
Wait, say more.
I
What
don't
do you
think
mean by
so.
that question?
I feel like I had never experienced anything like that before the really big episode, right? And so, but then since then, I feel like, and I don't know if there's like scientific validity to this, but just the lived experience feels like I'm kind of pulling myself out sometimes. Like if things are really, there's a lot of sensory input all of a sudden, or heightened emotions around me, or things like that. Like I will just sort of and kind of disconnect a little bit.
Yeah. I mean, I
But
think
I don't know if that's like a real, like legit thing that like once you do it, I mean, it's like getting back to the
Your
neural
body set a
circuitry, right? Like
precedent,
now, am
yeah,
I just
for
like
it.
better at doing that now because I have the circuitry?
your body knows that your brain, body, whatever, like
Yeah.
knows this is an option. So like, is it ever 100% necessarily like I can just choose to? I'm thinking about things
Well, I
from
mean,
the internet
Aang
that are
can't
like,
choose to go into the Avatar state. You know, like something has to really set him off.
that's fair. Like, but I do think, I mean, clinically speaking, there are patients who will be like, I know I can. Preston wants me to care about the his reference is so bad. But I think like, again, it's not 100% volitional, but anecdotally and clinically, a lot of patients will say like, I know I can just like dissociate. Like, I know it's an option.
Okay.
Yeah.
Yeah, I agree. Like anecdotally, I've seen that as well.
I mean, I think it's like if you kind of like, you know, you can actively like unfocus your eyes. It's not
Yeah,
quite, I
it's
mean,
like that, but your brain.
your spouse would probably not like if I said it's not quite as simple as that. And he'd be like, the eyes are
Oh, you'd get a lecture. Yeah.
whatever. He's fighting a different war right now. Just he's gonna like put us up next on like
Yeah.
podcast spreading
Put you on blast.
misinformation. I mean, he came on a couple episodes and was like, Preston, why are you saying that my medical humor content is bad?
Oh yeah, I remember that.
Yeah, I was like, oopsie.
Sorry, Dad.
That wasn't meant to be directed like that.
The last thing I'll just say, because I know we have to wrap up the episode soon, is just I think we've been circling around this as well in the episode, but our brains are good at doing things to help us establish patterns and to survive. And I think a lot of people who go through something that makes this a concern for them, like makes dissociation a concern, have in many ways, whether it's like what you went through in the hospital of being scolded or kids going through traumatic things, are somehow made or given the message that the pain and the suffering is their fault, and therefore there's something broken about their brain or themselves.
Mm-hmm.
And while we can help and we give this a diagnosis and not everyone experiences it, I also think there's something to be said that there's something deeply human and protective in the brain doing its job when these things occur after trauma.
Right. Because it's too much. Like it's just protecting you from the too much.
Mm-hmm. Yeah, exactly. It's just like everything's on fire, so let's just like shut the door and snuff out the oxygen.
Yeah. Like if there's nothing you can do about it, then, well, at least we can just not feel it.
Yeah. Or I guess even like a better analogy would be like, you know, like a circuit breaker. Like the voltage gets up too high and the circuit breaker just going to flip the switch.
Yeah.
And everything kind of shuts off for a second. It all still
Right.
works, but you have to like manually flip it back on.
Yeah.
Let things start to restart.
Chris, I'm wondering if you have any final kind of thoughts, especially given your experience as you're writing this book, things you'd like our listeners to know either about their patients or, you know, they themselves as people who have probably been through things, seen things working in healthcare, and your experience.
Yeah. So one of the things I always end my talks with that feels relevant here is like, you know, I talk about how patients and families and, you know, we've experienced this trauma and what the effect is, and I'm talking to healthcare audiences, but I'm also fully aware healthcare professionals see so much trauma every single day. Sometimes, you know, you might see more in a day than some people see in their entire lifetime. And then, you know, you're just expected to sort of normalize it and move along. And so I don't know. This is maybe the mom in me, but like, I just always am like, please take care of yourselves. Like, it's okay to feel your feelings and be a human being. Like before you're a doctor, you're a human. And like, that's good and wonderful.
Yeah. Being a human is an incurable condition.
That's right.
We all share
Darkest
it.
interpretation of that, but sometimes we don't have to just learn how to be patient, but be a patient. See, that's what you guys
Yeah.
Hey,
Aw.
there you
Get
go.
cut cut out of the
Producers
episode.
play red-tailed hawk sound.
Maggie was too nice. Get her out of here. All right.
Okay. Well, thank you everyone for listening. I know a lot of people were kind of asking us about doing an episode on dissociative disorders. This is kind of us really, I think more so wetting our feet with it. There's a lot of other things we can talk about. And I think a lot of people are requesting that we discuss more around borderline personality disorder and complex PTSD, which I think is a topic that deserves its own episode or several episodes. But this is kind of our start to talking about, some of the mechanisms or treatment options around dissociation as it pertains to trauma. If you guys like these types of shows, if you like having Kristin on here, if she has time to come back and do
Don't
other
tell me if you
episodes with
don't.
us
Just keep it to yourself.
yeah. Or you can tell us in secret and we won't tell Kristin.
There you go.
You can come chat with us
We'll
or
block you,
just
though, then.
DM us on Instagram at How to Be Patient. You can find us on our website at howtobepatientpod.com. You can always see stuff from Margaret at Bad Art every day, but it should be medium art every day, considering it's getting better, I think.
Okay.
And if you haven't done
Everyone's-
bad art for today, find something
Go
and
make some
do
bad
it.
art.
Yeah. I started to do paint by numbers.
I got
It's
one
actually-
too. I was #influenced by Preston. Can you believe
Hear
it?
that, guys? I can influence Margaret to do things.
I found out
You can always
once in
find
1
me
year.
on. You can always find me on TikTok at It's Presro. Or I'm Presro on TikTok at It's Presro on my YouTube, which is where also all of our episodes will be listed. Shout out again to everyone leaving the kind feedback and comments, and everyone who also leaves other comments too. Like someone just said too many ads, and they were
Period.
like the pre-roll
They said,
YouTube
"You
ads. Like
capitalist pigs."
it's like, it's all feedback. So I appreciate you saying that.
I also like the
thanks
guy
again
who
for listening.
comments first every time on the YouTube videos. He's our number one.
I like you, man.
Number one
You're
hero.
commenting
Shout
first.
out.
Yeah. It's different people, but shout out to you.
Oh, I thought it was
It might just be one on YouTube. I'll find your name and I'll
We'll have you on as a guest.
Call you up by name next time. Yeah. We're your hosts, Preston Roche and Margaret Duncan. Our executive producers are me, Preston Roche, Margaret Duncan, Will Flanary, Kristin Flanary,
Heyo.
Aaron Carney, Rob Goldman, and Shanti Brooke. Our editor and engineer is Jason Partizo. Our music is by Omer Benz V. To learn more about our program disclaimer and ethics policy, submission verification and licensing terms, and our HIPAA release terms, go to howtobepatientpod.com or reach out to us with any concerns at howtobepatient@human-content.com. How to Be Patient is a human content production.
How to be patient.
Thank you for watching. If you want to see more of us, or if you want to see, this is Lilac, she's my cat. She's going to be waving her hand at one of the floating boxes, which will lead to more episodes. Lilac, point to the other episodes. Lilac doesn't know what the internet is, but I swear they're there. They probably exist for real. But in the meantime, I'm just going to pet Lilac, and then I'm going to go dance in the background.